Hi everyone. I'm Tatiana Prowl. This is my husband Todd Gleason. Bear with us a moment here. We're just repositioning cameras. All right, we just need to plug that one in. All right. So thank you very much for being with us. Bear with us here. This is actually our first time using Instagram Live or Facebook Live. I'm usually a Twitter user, and my husband is a
Luddite.
A Luddite. He's a non-social media guy. So thank you guys for joining us. We're here basically to just give you guys information about COVID-19, about the Omicron variant in general, to take your questions. If you look at the invitation for the event, you'll see an email there where you can actually submit questions. I think that's going to be easier than trying to put them in a chat on either the Facebook or the Instagram, because we're doing this on two little phones and we're also trying to talk to you, so we're not going to be able to monitor those quite as easily. So if you do have questions, please send those to the email. If you put them in the chat, I'll ask our PTSA president to please forward those on to the email so that we see them. And we plan to post a frequently asked questions afterwards, so that if you didn't get a chance to ask something, you'll have a chance afterwards. So I'm Tatiana Prowl. I'm a board-certified internist and medical oncologist, Johns Hopkins educated and trained, and I'm an associate professor of oncology at Johns Hopkins, and I'm the parent of 3 kids in the Howard County Public School System. And this is my husband.
Hey, I'm Todd Gleason. I'm an infectious diseases doctor in the Navy. I work at Walter Reed, and we have the same kiddos in the Howard County system.
So we just wanted to start out by giving people a little bit of an update and sharing some things that we think may not have been clearly enough conveyed to the community, and that we think are going to be important to keep our students safe and our families safe and our whole community safe during this next several weeks, which we think is going to be very difficult. So what we know about the Omicron variant is that this is an airborne virus. That means that it spreads like smoke. So if you think about being in a room, for example, where you would be able to smell smoke, or you're walking through the mall and you smell Cinnabon or something, that's something that's spreading in an airborne fashion. So these are little tiny particles, if you will, going through the air, much too small to see, and this is going to become important in a moment for the reason I'm talking about. You got to scoot closer; they can't see you on whichever that one is. This is going to become important in a moment for the reasons we're going to talk about with the sorts of masks that we need to be wearing. The Omicron variant in particular is, like all the other prior COVID variants, airborne, so it spreads through the air like smoke. But what's different is that it's highly, highly contagious, much more so than the Delta variant or any of the previous variants or the original coronavirus, from March 2020. This is, along with measles, the most contagious respiratory pathogen in a century, the Omicron variant in particular. So for many of you who may have been using cloth masks, or even stopped using masks, indoors after the mask mandate went away, maybe after you got vaccinated or boosted, what we want to tell you is that this is so contagious that if you are not masked, or if you are not in a good quality mask, you are all but assured of getting infected if you're in an area where someone else is present and contagious. So I think, I'm going to sort of give my husband a moment to talk here a second, maybe about masks or whatever you want to talk about. We have several questions that have come in, and we're going to answer those. But we just had a few things that we wanted to say to begin.
So part of today is we wanted to talk about ways that you can protect your students and your families given the Omicron surge. And we've heard a lot about it being more transmissible, being more infectious, being more airborne, and we need to, what can we do with the masks? So there are a couple things, and one, you'll see a lot of articles on upgrading your mask, and I would say that you can think about this as minimal, better, and best. And best is really doing N95 masks, or you'll also see KN95, which just means that mask was certified by China's system of certification. That said, CDC and NIOSH, NIOSH, on their websites have a listing of different manufactured KN95 masks that they've actually tested using U.S. Standards, and so you can look there too. But that's the sort of like highest level protection that you can actually do, and those are available. You know, we used to have a shortage, right, early in the pandemic, and the CDC even said, don't buy these. We need them for our healthcare workers. You know, and now we're in a better place. And so the next thing would be to think about how can I upgrade my other masking strategies, and what there are some great videos online on how to loop and tie the ear loops on surgical masks. Really straightforward and short.
Actually, let's show you. Actually, we have a mask because like everyone has a mask graveyard at this point, right, in their home or their car. We are just like you. We have a mask graveyard too. So basically, the idea is when we say a surgical mask, what we mean is this kind of mask. So like they're often pale blue, but these are the ones that you can get kind of anywhere. These are the ones that you see on doctor shows with surgeons wearing them, and they actually do filter really well. There are 2 points to masking. So one is about fit, and one is about filtration. So for filtering, like if air actually goes directly to the front of the mask, even a surgical mask, particularly one that's listed as ASTM3, a 3-ply mask, actually does a really good job of filtering even things as small as the coronavirus. Where these masks kind of fall down is in fit. So they filter well, but they don't fit well. So when you go and you put this on, even if you put the nose piece on and you squeeze the little metal part, you can see that there's a whole big space here on either side, right? And if you have, and on the top as well. And you might be able to tell that if you wear glasses, because your glasses will fog up, because this is just hot breath that's going up there. So if you're somebody who doesn't have a huge face, like me, or even a person who does have a huge face, you often will have a gap around the mask. So the best thing, as Todd was saying, is to actually get a better quality mask, and we'll talk about that in a minute. But if you don't have that, or if for some reason you can't tolerate that, using this kind of mask, fitting it better and adding something on top of it works well. So the way that the CDC has a little video, we'll post this link afterwards, but basically what you do is you fold the mask in half, then you're gonna tie the ear loops so that they are next to the actual mask itself. You're gonna tie the ear loops to basically shorten them. And then when you do this, this is actually gonna enable you to turn in the sides of the mask so that now it's tighter, see? And you're gonna turn in these side holes like this. And then when you put the mask on your face now, you can see that it's almost more like a little cup, right? So like it goes right up against my skin. Everybody see this? So now we've got this good filtration in the mask. You can see that you can hear me just as well as before. So if you're thinking about being a teacher, for example, or a student wanting to answer in class, or a bus driver wanting to tell people to quit doing stuff, you see that we actually have better fit. Part of how you can tell you have good fit is you actually can see the mask moving in and out. So see this? See, I can pull it in and out. That shows you that I have a much better seal than I had before. So you want to pinch that down. You want to fold it in half. You want to tie those ear loops next to the mask where it joins and tuck the corners in and then put it on. An important thing to say about this is when you take your mask off, I see a lot of people, they have their mask on, and by the way, this is a new mask, so don't be horrified, but they have their mask on and then they're talking to people and they're like loving themselves. They're rubbing their own faces, they're taking their mask off and they're holding it like this and putting it in their pocket. The whole point of this mask is that it's capturing virus on the outside of the mask. So if you go do all this stuff to it, you are putting that virus on your hands, and then when you go and you rub your nose or you rub your eye or you eat something, you put your hand in a bag of chips, you've just infected yourself potentially with the virus, okay? So when you go to take these off, and this is really important because if students are going to be going to lunch, they're going to be taking a mask on and off. If they need a break from the mask, they might take it off outdoors, changing classes. When you take it off, just take it off by the loops. Don't hold all the stuff. Take it on and off by the loops, okay? So doing this type of surgical mask with
is
a cloth
great,
mask
and a cloth mask
over it.
over
Right.
is really good. I
And
mean,
that
it's a good
actually, yeah,
strategy.
so if you have a surgical mask like that, you put a cloth mask, maybe the same one you've been wearing all along, but wash it, because how long have you been wearing that thing? Put it over, but it helps the mask to fit more tightly. Wait, did I mess up?
Just turn it.
Turn this one. Sorry,
Whatever the Instagram
this one?
is.
Is this
The
the,
Instagram one.
is this the answer?
Is that
No,
better?
that's this one. Sorry, my 16-year-old is telling me that we need to turn this.
I think mine's Instagram.
Whoop, sorry. Wait, 1 second. This is the one that needs to be turned. Is that right, Isla?
Yes, I think.
All right, sorry about this.
Oh, how do we look?
All right, sorry about this. This is what I get for picking the phone up while we're in the middle of doing this. All right, come back together. Here we go. We're good. I think we're good.
Are we good?
Are we the correct way now?
It's back to how it was. It's fine. Just keep.
All right, so we might be sideways if you're viewing us on one of these. Is that an Instagram that you're viewing on? Okay, so that's this phone. So hang on. How about that? Is that right?
Waiting for it to update.
All right, so I think we're okay now. I'm sorry if we're sideways. As I said, we don't do Facebook Live or Instagram
Okay,
Live
we're good.
usually.
We're good.
All right, you can tell that this is not a big scripted show. So, but the bottom line is, if you don't have time to get a better mask, you should make time to get a better mask. But if you're having trouble finding one, and what you have today is a surgical mask, if you do that, if you fold, if you loop these, tie them here, tuck those edges in and put that on, and put a cloth mask over that, then you are actually going to have really good fit and really good filtration. And that is not as good as an N95 mask, but that blocks about 75 to 80% of airborne particles, whereas that 95 in an N95 means 95% blockage. So it's way better than what you get with just a surgical mask alone, which is 40 or 50%, and a cloth mask, which might be 20% or less.
Yeah, and I think a lot of people. We also have some questions already that we'll get to. And again, we don't have like a specific agenda or schedule, but a lot of people, think about the numbers and they say, well, N95 that still lets in 5% of things, and so I'll still get infected. But it's more, I think, consideration of how much time does it give you. So, if let's say like the virus needs 1,000 virions to get into your nose to cause an infection, and something is 50% effective, then it doubles the time that you have to not get infected. And then 90% effective screening or filtering is going to give you like 10 times the amount of time to not get infected. So it's more of a safety and time around that source that gives you that protection. So I really think that upgrading your mask and your overall mask strategy is super important. And of course, the same things apply, right? Maintaining distance as much as possible. I think what's on our mind and what's on a lot of parents' minds right now is like, when the masks come off for eating. And so we really have to, I think as a community, stop any eating in the rooms outside of lunchtime, right? Because we all know that that's happening still. That's important, and eating outside is really important, and I think we're not there yet, probably.
I think we need to get there.
Yeah, we
so
need to
this
get
is
there.
one of the things
in the winter. We have to do
right.
it.
This is one of the things that we have to talk about. So, I explain this. People say, a lot of people have asked me, why are the masks even that important? Wasn't this the whole point of the vaccine, or wasn't this the whole point of the booster, so we wouldn't have to do all of this stuff? And I like to describe this to people as layering protection. So this is just like what you do with your car, right? So there are things you do with your behavior where you say, I know that I'm going to be drinking alcohol. Not if you're a student, by the way, watching this, you're not supposed to be drinking alcohol. But for the grown-ups here, I'm going to be drinking alcohol. And if you are a student who drinks, this is actually relevant for you too. I'm going to get a designated driver. I'm not going to be the person who gets behind the wheel. So this is a way I'm going to modify my behavior. But we also say, then we're going to think about other technology, if you will, that we're going to rely on. So we know that seatbelts provide great protection, right? But we don't say a seatbelt is all I need. I've got a seatbelt, so I'm going to drink and drive. Or I've got a seatbelt, so I don't care that my car doesn't have airbags. What we say is we're going to layer all these protections. We're going to say, if I'm going to be doing something that's unsafe to drive, like having alcohol, I'm going to have someone who's not drinking to drive me. I'm going to make sure that my car has a functional seatbelt. I'm going to make sure that my car is a model year that includes airbags. And if you're buying a new car, you might look at crash test ratings, or you might look at whether or not that car has some other safety feature like lane change, awareness. You're layering all these protections. And why are you doing that? If you're like most people, you might have never had an accident in your life, or you haven't had an accident in years, but that doesn't keep you from still getting a designated driver and making sure you have a seatbelt and you're wearing it and looking at crash test ratings. You do this because the implications of having an accident, which for most people at some point is unavoidable, and that's the same thing as with this virus now, right? Everyone's going to be exposed. So you do all of these things so that when you unexpectedly get in an accident or you unexpectedly get exposed to this virus, you've got the best odds, right? It's not always going to keep you from crashing. Sometimes these things will keep you from crashing, right? Having a designated driver might keep you from crashing. Having a lane change, assist awareness thing might keep you from crashing. Having a blind spot indicator might keep you from crashing. Sometimes your car is going to crash anyway, and then you're going to be relying on your seatbelt and your airbag to make sure that the most serious thing doesn't happen to you. You don't end up hospitalized. You don't end up dying from that. You don't end up hurting somebody else because your car goes uncontrollably into the oncoming traffic. And this is really the same concept. You're layering protections so that you maximize the odds that you and everybody around you are safe. Is this going to prevent every single thing? Absolutely not. But it's going to prevent a lot of things, and when things do occur, it's going to make them less severe. So I think one of the major messages, we're going to talk about lunch in a minute because this is a huge concern of ours, and this is actually the thing that motivated us to do this whole thing. One of our concerns, though, is the fact that the message is not getting out about booster shots. So we actually have the vast majority of eligible people, age 5 and up, in Howard County now vaccinated. I don't know that data for the school system. I hope that Dr. Martirano or some of our Board of Education members are watching this, and I would love if they would actually share this information. If we don't have it, I think we deserve to have it as a school system, and I think that the members of this community with children in the school system deserve to know it. But what I do know is that countywide, the vast majority of eligible Howard County residents are now vaccinated, which is great news. What we have just learned in the last 24 hours from England, which is about 2 weeks ahead of us in their Omicron surge, is that people who are boosted have an 88% reduction in the likelihood of severe illness and hospitalization. And that is incredibly important because our hospitals right now are in various stages of overwhelm in our entire region. Washington, D.C. is in even worse shape than Maryland, but even us here in this area, our hospitals are really incredibly overwhelmed. We already have elective surgeries being canceled, and let me be clear that when I say elective surgeries, I'm not talking about a knee replacement that could be any time this person's their knee hurts, but it's not really urgent. I'm talking about patients with cancers that could be curatively treated and their surgeries are being postponed. We won't see the impact of that in the immediate term, but I can tell you as an oncologist that when we delay surgeries, curative surgeries for cancer, some of those patients who would not have developed a metastatic recurrence are going to have their cancers come back and die because of it. When we postpone things like a heart bypass surgery, which is in many cases not considered an emergency, it doesn't need to be done today. When we postpone those by a month, some of those people are going to have a heart attack and die. So the impact of this on our healthcare system, even leaving out the possibility that you get sick with COVID and you need to go get care, the impact of this on our healthcare system for anybody with any medical problem is dramatic. Even if you have appendicitis, even if you have kidney stones, even if you have a urinary tract infection, let alone COVID, it is not just possible, it is likely that you will have a difficult time being seen in a timely fashion in our emergency departments, and it may be difficult or impossible for you to get admitted to the hospital. So what we need to do as a community is go get booster shots. If you are listening to this and you have had a booster shot, good for you. But what I can tell you is that the majority of people who are vaccinated in this country and in this county have not had booster shots. We have 70 million people total in the entire U.S. population of 331 million who have had a booster shot. So not everybody is eligible at this moment, but a lot of people are eligible. If you are listening and you have not had a booster shot and you are eligible, that's the first thing you need to do when you get off of this. So how do you know if you're eligible? One, If you are 16 or older, so a lot of people don't know that 16-year-olds are already eligible. If you are 16 or older and your dose 2 of Pfizer or Moderna was 6 or more months ago, you're eligible right now. If you got the Johnson & Johnson single-dose vaccine and your dose of the vaccine was 2 or more months ago, you are eligible right now. Okay, so if you're already boosted, great, but you know someone who's not boosted. So what I want you to do is I want you to boost this information on social media. I want you to pick up the phone and call your family members, call your friends, call your neighbors, text your coworkers, whatever, and say, hey, have you gotten boosted? Go do this. There are appointments as soon as this weekend through the govax.maryland.org, I think, or .gov. We'll have to look that up. Can you actually look that up? And you can make appointments as soon as this weekend.
And I think we've seen in the news, right, that we expect the FDA to announce Monday that boosters will be authorized for 12 to 15. You know, we know about 16 and up, but 12 to 15, that's huge. And our kids are in that window, right? So we expect that the FDA announcement will come Monday, and then the CDC will look at that expeditiously, right? And probably, you know, mid next week or earlier, our 12, 13, 14, 15-year-olds can get boosted, and we need to really push that fast and hard because we're going back to school after winter break, and this is sort of a golden moment to really sort of get on this.
Mm-hmm. So, you know, again, every person who goes to get boosted now is actually helping us be much safer in January. So we know that we're going to talk about case numbers in a minute, but we know that if we can reduce hospitalizations by 88% in people who are boosted, if we can get a majority of our community boosted, not only the kids, but also everyone else in our community, because remember, our kids are not, it's not just about them. A lot of people say, we're not that worried about the kids, not that many kids have been hospitalized, not that many kids have died. What I will tell you is that, you know, hundreds of children have died of this in the U.S., and if you are one of those families, you don't care that that's a rare event. If that's your kid, that's your whole world. What we have seen in New York City is that hospitalizations of children 0 to 17 have gone up 5-fold in the last month. And the majority of those hospitalizations are actually happening in the unvaccinated groups. So they're happening heavily in the 0 to 5 age group, which is not eligible yet to be vaccinated. And they're happening heavily in the 6 to 12-year-old age group, which is very under-vaccinated compared to the older groups. So very, very few people who are hospitalized, very, very few children who are hospitalized presently in New York City are fully vaccinated, and none are fully vaccinated and boosted. The only people who are fully vaccinated and getting hospitalized in that age group in New York City are kids who have a reason that the vaccine may work less well on them, which would be immunocompromising medications like chemotherapy or medications for some rheumatologic conditions, inflammatory bowel disease and things like that, or kids who are immunocompromised from a condition that they were born with, an immune system abnormality that they were born with. So this protection really is strong, but if you aren't vaccinated or if you aren't boosted, you're going to be contributing to these cases and placing yourself at risk. Importantly, and this is a message I want all of you guys to get out as well, the boosters work quickly. The boosters work within 7 days to start providing protection, and they are providing maximal protection at day 14. So this isn't something that I'm going to suggest that we do and it's going to help us down the line. This is something that's going to help us by the middle of the month, right? If we can get people to go who are eligible now or would be eligible soon to go get boosted, we will dramatically improve our odds of staying safe as a community and actually being able to have our kids in school.
So Isla has a quick update on.
Oh yes,
The website.
so my child is helping here in the background. Thank you. So it's covidlink.maryland.gov is where you can go and actually get your appointments to get boosted. There are walk-ins available as well, both in Howard County and in Baltimore. So please actually plan to schedule that.
Yeah, I think so. We have questions coming in. I see them coming in, so we're going to try to maybe address some of those. We have some that came before this meeting, so I'll just address some of those now.
And then lunch.
And keep them coming in. Do you want to talk about lunch now?
Well, we can talk
Oh, yeah,
about lunch
okay.
whenever. We can-
Okay. So one question, really good question that came in was about mRNA vaccines. We just talked about vaccines a little bit, and why can't we just? It seems like it's a super fast way of making vaccines. Why can't we just march right along in step with the vaccine or variants as they come out? Why can't we just get an Omicron, vaccine and so forth? And so right now, the good news is that the current vaccines that we have, Pfizer, Moderna, J&J, as long as we get boosted, those antibody titers, they're good against Omicron and Delta variants, right? So, but the companies are watching closely, and they're saying if a variant emerges and our current vaccines don't cover it well, then they will pivot, and they're actually practicing that right now. They're actually going through sort of dry runs of let's actually make a variant vaccine against one of the prior variants and then test it and see if it works. So the Pfizer CEO, in June of this year, just said that if a variant emerges that our current vaccines are not good against it, they can have one in 100 days. And so, yes, mRNA technology, we've been using it for 30 years, developing it, and now we're bearing the fruits of that labor. And we can get these vaccines really quickly now, but it's actually, 100 days, Omicron's been in U.S. since December 1st. And so it's going to just run through us like a brush fire, honestly. And, we're not going to be able to be in step with the variants as they emerge, per se. But I think the technology is really good. And part of that is we kind of think that the future of vaccines are going to be more probably like the flu vaccine, where COVID eventually, we can't wait for that, but we're waiting for COVID to just kind of become part of the background of viruses that are circulating, and probably will be seasonal, and with flu in the winter, probably, we hope, eventually. And then COVID vaccine development is going to look at the variants and the strains that are out there, and then they're going to make an annual vaccine against that. That's probably the future. But right now, the good news is that the current vaccines work. But that was a great question. Thank you for that.
Actually, let me ask.
Yeah.
I saw one thing pop up. So one thing that we have learned now with people being boosted, and again, we've learned this from South Africa and from the UK, both of which are a few weeks ahead of us, sort of in their surge. What we have learned is that when you get a third dose of the vaccine, we keep calling it a booster. That was the language that was originally used. But honestly, a lot of our vaccines require multiple doses. Any of you who have children, which is all of you, unless you are a child student here watching, any of you who have children know how many times you had to go to the pediatrician and get the MMR and get the polio, get all of these different vaccines. Many vaccines have 2 or 3 or 4 doses required to be considered fully vaccinated, and might even require a booster several years hence. So that's not unusual, and you shouldn't feel like that's a sign that the vaccine's failing. I think this is a sign that we're learning as we go, because the need to develop this vaccine emerged very urgently in the setting of an ongoing pandemic. But I think what we're learning is that this is a multi-dose vaccine, the same way that hepatitis B and all these other childhood vaccines are multi-dose vaccines. I don't think this means that you're going to have to be taking this vaccine every few months forever. We're going to be constantly playing a cat and mouse game where we have to change it for a new variant. It could happen, but I think it's less likely. A lot of people have focused on antibody levels and how the antibody levels fall. Some people have gone and gotten antibody tests to try to figure out if they're protected well, which there's not great data to support doing that, honestly, at this point. But a lot of people have focused on antibodies. We now have some data looking at other parts of the immune system, things called T cells and so forth, other cellular immunity, other parts of the immune system that show that once you have had a 3-dose series of these vaccines or a 2-dose series in the case of people who got Johnson & Johnson, and then a booster of one of the other types of vaccines, or a second dose of Johnson & Johnson, those people have very robust, highly protective immune responses against severe disease. So some person asked, I see popped up here, how long does the booster shot last, and will another booster shot be necessary? I don't think we know the answer to that yet, but I am hopeful, having seen these recent results about these other aspects of the immune system. What we have seen across the board is that if you have 3 doses, that you really do have good protection against the thing we most care about, which is severe illness, development of hospitalization, or even death from COVID-19. I think that we will get data on the benefit of a 4th dose of vaccine for the person who asked that. I think the last name was Kennedy. I'm sorry I didn't see your full name, but we will get good data on the benefit of a 4th dose. Just this week in Israel, a study was launched in healthcare workers, actually giving them a 4th dose. And they were, I think, at least 3 months after their 3rd dose. At the time they're getting a 4th dose, they're going to be looking at the blood to see the immune response, and they're going to be looking for side effects. And the results of that study are actually expected out in about 2 weeks because they're in the middle of this surge, so they're just getting a lot of cases, same as everywhere else. So the answer is we'll know what it does to our immune response, and we'll have information on how safe that is sometime in January. We'll have information as we go forward on whether or not that booster, an additional booster could be needed, or even further boosters beyond that. But what we know right now is that 3 doses is really good. So one question that I saw pop up earlier, and I'm sorry I didn't see your name, one question I saw pop up is, what about people with cancer, or what about people who are immunocompromised? Does the booster work for them? And so this is more complex. So we know that there are some people who are immunocompromised who still form just as good an immune response as anybody else. But we know that there are a larger percent of people who are immunocompromised. So those are people who are on chemotherapy or other medicines that make your blood counts go low. Those are people who are on biological medicines for things like lupus or rheumatoid arthritis or inflammatory bowel disease, things like that, autoimmune problems. We know that some percentage of those patients don't form a good immune response to 2 doses, but they do get a benefit to a 3rd dose or even a 4th dose. And the groups that I think are particularly worrisome to me are patients who have had a solid organ transplant or a bone marrow transplant, so solid organ or bone marrow stem cell transplant. Patients who are on therapies called CAR T cells, which we use fairly often for cancer. Those are the groups that really worry me most. Patients who have hematological malignancies like leukemia, in particular, that's another group that I worry about. If you are in an immunosuppressed or immunocompromised group and you are eligible to get vaccinated, you are eligible to get an additional dose. So if you go, so that would be like a 4th dose if you've already gotten 3. If you go try to book that on the websites and you just look for 4th dose or something, you often won't see that. If you go look and you put an additional dose or additional dose immunocompromised or additional dose immunosuppressed, you'll see a special link that takes you to a place where you can attest about your high-risk condition, and then you can actually be scheduled for that extra additional shot, that extra booster, if you will.
How about this specifically?
Are you hearing about cancer patients having a rougher time even if they're boosted? So
With Omicron.
With Omicron. So we haven't talked as much about Omicron specifically yet. What we are seeing in general, and again, we're still learning about this in our own population, the data that we're talking about are mostly from South Africa, where they sort of had the earliest peak of cases, and their population is different from ours. Their population is notably younger, and they have fewer of certain comorbid conditions than we have in the U.S. For example, things like obesity, cancer. However, what we are seeing is that patients in general with Omicron are getting less sick than they got with the previous variants, which is great news. It seems that this current variant does a less good job of getting deeply into the lungs than the original coronavirus or the earlier variants. And that seems to be resulting in shorter hospitalizations for people who get hospitalized and a lower likelihood of dying in particular, which is great. What we do see, however, though, is in the U.S., the group of patients who are unvaccinated are continuing to have severe illness. So I can give you data for the state of Maryland. So as of 2 days ago, we had 8.8% of Marylanders who were completely unvaccinated, and they accounted for 76% of our current hospitalizations due to the variant. So I think that what you should take away from that is 2 things. One is that if you are unvaccinated, you are really at high risk. We know from South African data that having had COVID previously does not protect you, period, does not protect you. It provides you almost no benefit against the Omicron variant. That's different than with some of the previous variants where people who had been infected before and then were exposed to Delta variant or Alpha variant, one of these other variants, they actually did have some protection. With Omicron, that is not the case. If you've had COVID before, you are the same as somebody who never had COVID in terms of your protection against this current variant. So it's really important for you to go out there and get vaccinated and get boosted. I think the other thing that you should take away from this is I've told you that our hospitals are overwhelmed in the state, right? I've told you that our hospitals are overwhelmed in DC. Both DC and Maryland have some of the highest percentage of eligible people vaccinated of anywhere in the country. And I've just told you that with 8.8% of our Maryland population, Maryland adults unvaccinated, that they account for 3/4 of our hospitalizations. So what that tells you is that it doesn't take that many people being really susceptible to this virus to cause a major problem in our healthcare system. If we have people who are unvaccinated or people with this variant who are unboosted and they all need to be hospitalized in a short period of time, this will cause collapse of our healthcare system. I've been a physician for almost a quarter of a century. I don't use a phrase like will cause a collapse of our healthcare system on social media without carefully considering that. I can tell you that it will cause collapse of our healthcare system if everyone gets sick at one time. And this is part of why we also wanted to do this, to talk about what we need to do as a school system and what we need to do as a community to make sure that we don't all get sick simultaneously.
Yeah, and we're the guarantors of this session, but there are a lot of people in the audience, right, who are on the front lines working against COVID. So please share in the chat how things are at your hospital as well. Just to tag on to that, one of the questions that someone asked was, I heard that Omicron spared the lungs. You'll see that statement out there. Part of that came from an animal study like 2 days ago, New York Times yesterday, I think. And they looked at hamsters and other animals and found that it was mostly in the nose and the windpipe and not so much in the lungs. And we are seeing that right clinically. But the thing that the person who asked the question said, why are we seeing hospitals overwhelmed then if it's just cold symptoms? And you're right. You're right in your question in that it's just the overwhelming number of cases all at once. Mm-hmm. Where you're going to have a percent of people, mostly are the unvaccinated, who are getting the more severe disease. And so it's just a numbers issue, and then that's when our hospitals get overwhelmed. And then the other question was, some have asked, can I tell based on symptoms, do I have the new variant or not? And yeah, we've seen less of loss of taste and smell, but we still have seen it. And in the unvaccinated, we see people present very similarly as before, fever, cough, shortness of breath. In the vaccinated, we see maybe a different sort of clinical presentation, and it can be as subtle, I think, as like scratchy throat, sore throat. You feel like it's your allergies, runny nose.
Yeah, congestion.
Yeah, and so just get tested if you have those symptoms. As my wife can attest, I'm always sniffling from allergic rhinitis and coughing. And I get tested a lot just to make sure that I'm safe to see patients. But that was a good question.
Safe to live in my house
Yeah.
With our family. Yes, yeah, we have a dog to whom 2 members of our household, including this guy who adopted this dog, are allergic. So yes, we're doing lots of testing in our household.
I don't know this one, do you know?
So we can actually come back to this question. Okay. So another thing that we wanted to emphasize is the issue with testing. So this is a huge challenge right now because we know that the amount of tests that we have available as a country is completely insufficient. My understanding is that we also don't have sufficient tests as a school system to consider being able to do surveillance testing of our students right now, students and staff right now, which would be the way that we could be much safer. So I want to say a few things about that. So first of all, test supply is expected to increase. So the Biden administration has purchased a large quantity of tests, and they're actually going to be shipping these to people's homes in the first half of January. It's not totally clear to me yet if this is just going to automatically happen, like if you have an address, you get tests at your house, or if this is going to be a process where you request these online or something and then they mail them to you. But I know that tests are going to be going to every household. They will still not be sufficient in number to do the kind of screening that we need to be able to do to be confident that there are not going to be people infected in our schools. There will be people infected in our schools. It is a guarantee. I will go farther than that and say there will be people infected in every single classroom this week. Every classroom, without exception, we will see it. And why do I say that? Yesterday, we had 500,000 confirmed cases reported in the U.S. as of midnight for just yesterday, for just New Year's Eve, with only 23 of the states reporting. So when you consider that that doesn't even represent half the states, when you consider how hard it is to get a test, if you've tried to get one for any reason, it's tough to get an appointment, it's tough to get it soon. It's tough to find rapid tests. I know that we have driven all over the place, gone to 6 different pharmacies and grocery stores looking for tests and found all the racks empty. So what we know is that we are only capturing or ascertaining a small percentage of the cases that are actually occurring. Some people are asymptomatic. They don't even know that they need to get tested. Some people are symptomatic, but they can't find a test anywhere, either officially or unofficially. Some people are symptomatic and they find a rapid test somewhere, or they already had one at home and they do it at home, but there's no way to formally report that. And then some people actually go get the test, legit at a urgent care or at a pharmacy or someplace. But only that last group that are getting formal testing is counted. So when we think about the fact that we had almost 500,000 cases yesterday with less than half of the states reporting and all of those other people being missed, we are having millions of new cases per day. So what that means is that you can be assured that there will be a lot of people in that school building who are going to have COVID on Monday and Tuesday and Wednesday and every day after that for as long as school manages to stay open. And why do I say as long as school manages to stay open? I'm going to be very honest with you. I don't think that we're going to be successful at this. Even with all the things that I'm saying to do, I think that January is just going to be a hard month, and I feel like you have the right to know that. The problem that we have is that this virus is incredibly contagious. It spreads exponentially. So this is a good math thing. If any of your students are watching or you're going to talk to them after this, go Google. There's a great video online. Google exponential growth and M&Ms and watch this video. It's like 2 minutes long, but it basically just shows that if you have 2 M&Ms and then they become 4 and so on and so on and so on, that you will rapidly get to a mind-boggling number of pieces of candy in a very short period of time, in a matter of days. So this particular variant is doubling in the population every 1.8 days. So if we say yesterday conservatively we had 2 million cases, we're not starting with 2 M&Ms, we're starting with 2 million cases just from yesterday, not considering the whole month before that. You can do that math for yourself and see that almost the whole population, if we do absolutely nothing to mitigate it, almost the whole population is going to be infected probably in January. So whenever I say this, somebody predictably and appropriately says, well, if we're all going to get it, shouldn't we just all get it and be done? And the problem is this. Just like Todd said, when you have a small percentage of people, and it is small, it's been small for all of COVID to be clear. If you have a small percentage of people getting sick, really sick, but that small percentage is a small percentage of 331 million, which is how many people we have in the US, or 330,000, which is how many we have in Howard County. That's a lot of people to get sick all at once. That's a lot of people who need to go to urgent care or the ER. That's a lot of people who need to be hospitalized. That's a lot of people who need to be put on a ventilator. And unfortunately, that's a lot of people who end up dying. Even a small percent of a huge number is a huge number. So this is the real critical concern of this moment, is how are we going to keep everybody from getting sick all at once, which will overwhelm our healthcare systems. We've already seen this in DC. So a couple of days ago, what we saw in DC was that some ambulances waited as long as 8 hours to drop patients off at the hospital. That is, of course, horrifying if you've ever called 911. But if you think about the upstream effect of that, so what happens? Now this patient, this poor person is sitting in their ambulance, they can't get in because the hospital is too full. Everybody who's calling 911 after that is going to be waiting longer and longer for anyone even to show up, let alone to transport them, let alone to actually be able to be in front of a healthcare worker getting the care that they need. So having everybody get sick all at once is going to be, from a healthcare system standpoint alone, a calamity, period. It's going to be catastrophic. The additional issue is this. We know that it's not just about healthcare. I think that healthcare workers, that tends to be our focus, right? Is we don't want everybody getting sick all at once. We don't want our hospitals overwhelmed. We don't want unsafe conditions in our hospitals. We know that we've lost 20% of our clinician workforce since March 2020. 1 in 5 of our colleagues have quit medicine because this has just been too much and they needed to be home taking care of their families, or they were just exhausted or burned out, or whatever the case may be. 1 in 5 have quit, and 1 in 3 say that they plan to quit in the next year. So the problem I think that we have is not just this impact on the hospitals this minute, but this impact on our healthcare even going forward. The more proximal problem that we have, though, is that it's not just going to be students getting sick. It's going to be everybody that's necessary for school systems and society to function. So you probably realize that it's not normal that we had 7,000 U.S. flights canceled on Christmas weekend due to Omicron. We had about 1,200 canceled yesterday. That's not normal. You've never seen this in your life. So for people that say this is exaggerated, this is overblown, we've never seen anything like this. Have you ever seen NFL games, NBA games, major college football rivalry games canceled due to a virus? No, never in your lifetime, let alone all these things happening at once. So I think we have to realize that we are in an unprecedented situation. Or to use the language that came from a school system email where they said we wouldn't go virtual, or people wouldn't being able to be schooled virtually or something, except in the most exigent of circumstances. Like, these are pretty exigent circumstances. You don't have 7,000 flights canceled in the most busy travel weekend of the year if this isn't a really big deal that is disrupting every single sector. So our concern is that we think that people are comparing the wrong two things. People are saying, should we go virtual now and enable people to go get boosted, recognizing that we'll have a growing part of our population eligible to get boosted, and that we have the vast majority of the U.S. already eligible and not boosted, and those booster shots would work quickly? Should we go virtual to allow that to happen, to allow time for everybody to get good masks, which we know people don't have at this moment, to allow time for the test capacity to increase, which is expected to happen, all of that imminently in the first half of January? Should we go virtual, or should we just go? And I think that that's the wrong comparison, because when we say, should we just go, that assumes that we're just making a choice to go and it's going to work out. I don't think it's going to work out. I think you're going to see teachers rapidly getting ill, cafeteria workers rapidly getting ill, bus drivers. We all know, I mean, we're driving our kids because of the bus driver problem all year, and believe me, that is not easy for 2 doctors to be driving their kids who go to multiple schools with different start and end times all year. We have been doing that all year since September because we don't want them to have to get on the bus as early as they would have to be with a double route. Okay, so we already know that we have shortages of all these people. We already know that it's incredibly difficult to find a sub. So if we think about losing, even for just a few weeks, a couple, even just losing for a couple weeks from a couple of these different groups all at once, it's going to stop. What's going to happen when we have 40 bus drivers total for Howard County Public Schools? Are we going to still go to school? We're not going to go to school. What's going to happen when a third of the teachers are out sick? Okay, maybe you could find subs. Good luck. I don't think you're going to find that many subs, but if you do, they're going to get sick. And importantly, all the students are also going to get sick because they're going to be unmasked together at lunch, and that is going to be a daily super spreader event. So I think that in the best of circumstances, what we would have is a patchwork situation where a ton of parents are having to drive their students to school. For parents who have to work or who don't have a car or whatever, who have transportation issues, you're going to have a bunch of kids who are just inequitably left at home. And I think that you're going to have a lot of students out sick without educational supports at home beyond what they're currently allotted, which I believe is contact with their teachers twice, a scheduled contact with their teachers twice a week. It's certainly not instruction. That is the situation that we're going to have. I think that if we do have students in school and we say, well, we're just going to let them all get sick sick in waves and whatever, and all have substitute teachers there for the next 6 weeks, I would argue that we're not just sending our kids to school to have a place for them to go and be with another adult for 7 hours. There are truly some parents who are relying on the school system for childcare. Believe me, we are 2 doctors, our kids are older now, but we have been those parents. We get that. But we're sending them there for instruction. We're not sending them there for babysitting. If it were just babysitting, we'd hire babysitters. And if we have our kids at school not being taught by the teachers who know their subject, not being taught by teachers at all, in fact, just with substitutes, instruction isn't occurring. And that is not right. Because what we know is that there are families who have more resources, who will get tutors, who will sign up for the SAT prep classes, who will do all the things, and their students will be okay. And all the students who don't have those resources in their home, who don't have parents who can help them with pre-algebra, who don't have parents who can afford to hire them a tutor, all of those students will be left behind. I guarantee it. I guarantee it. And the disruption that is going to occur from having waves of students, bus drivers, cafeteria workers, teachers, administrators out, as not to mention the students out, is going to create a long period of disruption. I think that if we send our students as planned on Monday, doing exactly what we did before the winter break, we are setting ourselves up to fail. I want to be very clear on that. And when I say this, people say, well, it's Saturday. What do you want us to do? And I'll be very clear here. I appreciate that teachers and administrators and the Board of Education have had an incredibly hard job to do. And I commend you for doing it. You have had to respond to this on no warning, get everybody devices, figure out internet access, figure out what you were going to do for the kids who still needed in-person supports, figure out how you were going to get lunches. You have overcome extraordinary challenges. However, we have not planned appropriately for this situation. And this is a situation that, frankly, we needed to plan appropriately for a year ago, because this virus has been known to be airborne for a year, and we just had a variant that was not sufficiently contagious or didn't escape our vaccine protection as well as this one does. And now we have this variant, and this variant is basically like a pop quiz, except it's the highest stakes pop quiz ever. So when people say, it's Saturday, what do you expect us to do? I say, I'm sorry that you didn't prepare all year for your final exam, but you better figure out a way to make this happen. So I think that it's a lot to think about. Is there a way to do everything that needs to be done to make schools safe by Monday? I personally think it's not possible. I'm just going to be very honest with you. I think that if we had a couple of weeks of planned either delayed return to school or virtual learning, that it would enable us to do a bunch of things that would make school safer. What would those be? That would be getting everybody who is and will soon be eligible to get boosted. They'll have protection within 7 days, and they'll have full protection within 14 days. That's something that could be done next week. For everybody who's 16 and older, that's something that could be done today. So that would be one thing we could do. We could ensure that every single student and staff member has a high quality mask in their hand. These are not that expensive. They're $1 each. I'll buy them for my high school, okay? I think that this is an investment that our school system should make. I know that the governor has specifically allocated funds to schools for COVID. I would suggest that spending the money on this is something that could be done and should be done so that every student walking into school who doesn't already have a high quality mask on their face is handed a couple and at minimum one mask to have in their hand on the day that they go back to school. I think that we could get more rapid tests, which we know are coming anyway in early January, which would enable us to at least periodically be testing students and staff and excluding from the building to the extent that we can people who are sick and who are going to be spreading the virus to hundreds of other students. And we could make a plan for lunch. So the plan for lunch, I think, is critical. I'm talking entirely too much because I think he's looking something up to tell you guys. But the plan for lunch, in my opinion, is the one thing that makes this almost impossible as it's currently proposed. Do you want to be on the screen? Almost impossible as it's currently proposed. So the problem is this. We have seen, I can tell you this has happened even with my own physician colleagues who were fully vaccinated, who were boosted, and many of them even took a rapid test before an event. We had this happen with multiple holiday parties, and there have been multiple stories like this in the news as well, where those people gathered, one person in some of those gatherings was asymptomatically infected, and their viral load was still too low. They were still too early in the course of their illness or too late in the course of their illness for a rapid test to detect them. The attack rate in that case, which means the percentage of people in the room who will end up getting infected if there's one contagious person in there, the attack rate in those cases has been 80% or higher in most, and in some cases 100%, meaning almost everybody in the room is going to get infected. The other thing we know is that this COVID variant, the Omicron variant, can stay suspended in air. Remember I told you it's like smoke? It can stay suspended in air for 4 hours. So what does that mean? That means if you are a D lunch and somebody was in there for A lunch or B lunch who had COVID unmasked for a half an hour eating, that virus is still in the room. So if that room is not well ventilated and not well filtered, the people in that room after them are going to inhale the virus. I think that the only way that school can be done safely is to not have people eating together indoors with our current filtration system. No amount of HEPA filters are going to make that safe enough. On planes, for example, which have some of the most advanced HEPA filtration systems on Earth, in hospitals, for example, what we have seen is that since the Omicron variant came along, infections in those settings in people who are unmasked have increased dramatically. And from the FAA, we just saw data that since Omicron became the dominant variant in the US, that the likelihood of getting a confirmed infection from a flight is threefold higher than it was when Delta or any of the previous COVID variants were dominant. So what we know is that even in those HEPA filtrations where in a plane you have the full cabin air being exchanged once you're in air, not on the ground, but once you're in air, you have the full cabin air being exchanged somewhere between every 6 to 15 minutes. Still, the risk of getting Omicron on the plane now compared to getting a previous variant is threefold higher. Our school systems, it's great that in Howard County Public Schools, my understanding is now that every classroom has HEPA filters. Hopefully our cafeteria does as well. But I can tell you that for sure, they're not as good as what the plane has, and they're not as good as what hospitals have. So if there are kids or staff in the cafeteria who have Omicron, it will go through the cafeteria like wildfire, period. And there's just no two ways about that. So how do we approach that? I think that we've thought about a lot of things that we could do. I think that the most sensible one is people eat outside. It's January. That's the problem. The good news is we live in Howard County, for those of you who are local watching. We don't live in Minnesota. We don't live in northern Canada. It's not minus 30 degrees. It's cold, but it's not impossibly cold. People go camp in this weather, okay? I think that the single safest thing to do would be that we have meals outdoors. I think that I've heard from some principals that they've had concerns about whether or not they will have people to staff that. Will they have teachers or administrators or anybody who can walk around outside and just keep eyes on students, recognizing that the school system is responsible for students during their day? I'll say two things about that. First, I don't know what the staffing issues are. That's completely outside of my purview. I can tell you that our PTSA is engaged. Everybody who's on this video is on this video. We're engaged. We'll personally sign up for shifts to walk around the outside of our school and keep eyes on students who are eating outside. I think that considering the situation, you would find volunteers who can help with this. And we personally are raising our hands to be two of those volunteers. And I've got lots of friends who have kids in the school system who have also said, I would absolutely do that. I think that this is an opportunity for us to utilize volunteers, because our goal, even though that might be hard, maybe we miss a little bit of work to come staff lunch, each of us once a month or something, but that's going to be far less disruptive than having our children home for 6 weeks because the schools unexpectedly closed when everyone got sick with COVID and we couldn't even staff having the buildings open. So I think that is choice number one, in my opinion, is people are outside. And another reason that I say I think it would be valuable to either delay our reopening or to do virtual for a few weeks is to give us an opportunity to prep for that, to figure out what is needed. Do we need volunteers or do we have sufficient staff? Is that different from school to school? Where's the sign up? Who's going to sign up for the shifts? Let's get out there and have the Google form where people can say what shift they're going to cover. Let's get our PTAs involved in that process of helping to identify volunteers. What will we do when there's inclement weather? Do we need to have some sort of tent or covering, or how will we handle that situation? Because it will arise. It's January. If the weather's really inclement, presumably we'll be closed. But what if it's just cold and raining and 35 degrees? How are we going to approach that? I don't think that that's something that any of us can decide and like stand up the plan, whatever the plan is. We can't do that in 2 minutes. We can't do that in 2 days. It's going to take a lot of people thinking about this, and we volunteer to be among those people. I think that the second best choice, if we are unable to have meals outside and snack, by the way, for schools that have little people who are more likely to be unvaccinated and who frequently have snack in the room, I think if we cannot do that, or we cannot do that at every school for some level, or we cannot do that school-wide, then we need to think about how can we improve the ventilation and the filtration in the places that people eat. So the obvious way to do this is open the door, right? Physics is on your side here. Hot air is going to rush out, cold air is going to rush in, and you're going to have air exchange. And does that mean that there won't be virus in the room? No, but it means there will be a lower concentration of virus. So for somebody who is vaccinated, and we hope after this session boosted, maybe that's enough to keep them from getting infected, or maybe that's enough to result in fewer infections. Okay, so just creating airflow. And again, I think this is something where you have to prep for this. You've got to be able to get the word out to students and families and be confident they've received it, that like, hey, we know you guys love wearing shorts all winter, and nobody uses their lockers, but you might actually need to get lockers assigned this year, and you might actually need to bring a coat or wear 2 sweatshirts or bring a hat or whatever the case may be, because it's going to be cold if you do that, right? It's going to be cold, and we have to be prepared for that. And so I think we want to make sure that we've got students and families having the supplies they need. If people need coats or whatever, then we refer them to places that they can go and get a winter coat, get a hat, get something warm, but prepare so that it's feasible to actually have those doors open. And then the third thing is devices that improve filtration. So there's something called a Corsi-Rosenthal box. So that's named for 2 different aerosol scientists that created this. And these are basically a $20 20 by 20 box fan, like you can get at Home Depot or Lowe's or Amazon or anywhere like that. And then MERV 13 filters of the same size and some cardboard. And you basically make a cube, and it's pulling the room air into that, and it's filtering it, and the filtered air goes back out. These have actually been tested. I can post a news article, on the page after we finish this. But these have been tested, and they actually remove 90% of circulating virus from the air. So I had mentioned this, I know, to some of our own school staff, and they, I think, passed this on, and we're told we don't need that. The HEPA filters we have are better than that. And I want to be clear, I'm not talking about replacing the HEPA filters. The HEPA filters are unquestionably better than that. The problem is we don't have enough HEPA filters to adequately filter our cafeteria so that no outbreaks are going to occur, period. We don't. Because like I said, even in planes, which have the world's most advanced filtration systems, we're still seeing outbreaks, right? And those are smaller spaces that you need to filter. So these boxes are easy to build. They're simple to build. There are YouTube videos. You can watch them online. Like I said, they've been tested by aerosol scientists. Actually, a lot of colleges are using these right now in their classrooms to stay open. They filter 90% of the virus from the air. You can build one for $40 or less. And if you had a few of those in every cafeteria, which they can be built in 15 minutes. Literally, if you can wrap a Christmas present, you can build one of these. You could need like tape, the filters, the box fan, and some cardboard. It's not hard to do. It could even be a project that our National Honor Societies or our PTAs or whatever do with families in the parking lot. It could be a community building thing during this brief period of time that I'm proposing that we consider being virtual in early January. If you deploy those in cafeterias and you open the doors, it is going to be still not as good as being outdoors, but 1,000 times safer than just going in and having lunch the way we always have lunch. All right, I've talked way too much. My husband's been reviewing all the questions that everyone's sending, so I'm going to let him do all the talking now.
So,
for a long time. We'll be over here.
That's awesome. That's totally awesome. I think there are a lot. I think we can all see what's in the chat, right? And so I think there's a lot of discussion about why aren't we going virtual now? Why not? And what is the criteria to go virtual? Why isn't the Board of Ed? Why isn't the superintendent? And so we're not, we don't represent them, right? But we have discussed this opinion that a strategic pause of a period of time, like 2 weeks right now, would be excellent to allow vaccination of our booster shots for the 12 to 15 population, and to make sure that all of our 16, 17-year-olds are also boosted, make sure everyone has gotten that third shot if we can do that. And you know, that would be amazing as well, to get masked up appropriately and to allow time for testing. If you look at some school systems that do it extremely well, they do screen students with tests, and that would be a great modality to use. We've also discussed that, and supply may be an issue. But I guess the other thing too is, some of you were saying, you know, the decision makers are not watching this, or they're not in the room. They've certainly heard all of this, and I think the general shared value in this group watching is that we value in-person instruction, but not to the detriment of the health of our students or our parents or all the folks that work to be the guarantors of that student experience. And so we feel like this pause would be good for actually successful in-person instruction, to get the greatest amount of it this year, as opposed to just going, you know, damn the torpedoes straight ahead. So, but there've been other questions that have come up, but thank you for the discussion. So some have said that the rapid test that they've been able to get from Amazon, it came in 5 days instead of 2 weeks. Thanks for that. We got ours from Walmart.com.
Yeah, and we found
Thinking pretty
them
quickly.
from iHelpLabs.com
Yeah.
as well. There are places that, you know, the problem is the availability is just rolling, right? Like sometimes this place has them, and then everyone says, "Hey, this place has them," and then everyone goes there, and then they sell out, and then another place has them. I'm doing my best to try to share. As you could probably see if you've been with us this entire time, and like our whole calamity of phones being sideways and stuff, you probably realize that I don't do Facebook Live or Instagram Live ever, and I don't use these platforms as much as Twitter. I do tweet a lot. My Twitter handle is @TM, M for Michelle, TM Prowell, and I try to tweet about, you know, availability of tests when I find them, or mask places when I find them. A good place actually to recommend. That's a nonprofit that was actually set up initially to serve healthcare workers during that original surge in March 2020, when there was a shortage of all PPE and a shortage of everything, is Project N95. So they are several people who were formerly in government. Andy Slavitt, who was one of the Biden administration advisors for the first year, is involved with that. Several other people involved with that. But basically, they buy vetted PPE of all kinds, surgical masks, N95 masks, tests as well. So these are all vetted products, and they buy them in bulk, and then they resell them at cost. So they're very affordable, and the people there are super helpful as well. If you're looking for tests, if you're looking for masks, they are there 365 days a year, and at this nonprofit, and they are incredibly helpful. They will get on the phone with you and help you figure out a mask that fits your face, or, you know, where can you buy tests online. They're just really super helpful.
And are the rapid tests good? People have asked that, and yes, we used to say like asymptomatic, the rapid test can be as bad as 40% detecting infection. That data is better now, and it still detects the current variants that are circulating right now. So the thing that can help that, like the sensitivity can be like 80%. PCR is the best.
You have to define what sensitivity is.
Yeah, so like how good is that test at detecting the infection, basically? So, you know, and if someone doesn't have symptoms, that test is, you know, maybe positive less of the time, but they are good, and particularly like if they're repeated. So some of these rapid tests that we have at home, you can do it. It might be negative today. If you repeat it in 1 to 2 days, then it can be positive. And so sometimes used like that longitudinally, they're better. So I think having a home supply of rapid tests is helpful, and getting tested if you have any symptoms at all. Remember, it can be like subtle, like allergic rhinitis. Just go get tested.
We should address this issue of accuracy, though, because I think people are getting mixed up by this.
Yeah.
I think rapid tests are good for something very specific. Rapid tests are, this is an oversimplification. If there are physicians watching, don't say that's not exactly true.
Yeah.
This is an oversimplification, but I think this is the message we need to give. Rapid tests are good at helping you figure out if you're likely to be contagious, because what they really, where we see them fail, where we see them be negative, is when people don't have enough virus in their nose for it to be picked up and identified as positive. Right, so this is why some people say the rapid tests aren't as good, because my PCR was positive but my rapid test was negative. That PCR tells us, is this person currently infected, or have they even been recently infected? They don't necessarily tell us whether you're contagious at a given moment. The rapid test is the better test for telling us, do I have enough virus right now that I'm likely to be able to spread it to someone? And so they are very sensitive to changes in the level of virus. So one of the challenges with the Omicron variant in particular is that it's so contagious, and the incubation period, so that's like the period of time until you're exposed to when you get sick, basically, when your virus levels really start to go up, is shorter. So with the previous variants, that was 5 days or 6 days. With Omicron, that's only 3 days. And so what we have seen is that sometimes even people that are really trying hard, I got asked this question a ton about Christmas and New Year's Eve, is it okay if we're all vaccinated and we did a rapid test right before, are we totally sure we're safe? Because my grandma's gonna be there and she's 92 and she's being treated for cancer right now or something. That in that case, you might still decide that you want to gather because it's worth it enough to you, right? You feel like this might be our last Christmas, we really want to get together, and I don't fault you if you make that choice. I think the thing we have to think about in the school system, though, and then we have to think about in broader society, is that because that incubation period is short, you can have a test that's negative, truly negative, you're really not contagious or even infected yet, and then in a short period of time later, now it's positive and now you are infectious, and if you're not testing again that soon, you don't recognize that there's now a risk. So I'll give you a specific story. There was a plane that took off from Miami a couple of weeks ago. There was a plane that took off from Miami. Everybody on the plane was required to test negative before travel as a condition of getting on this international flight to Israel. Israel also tests all incoming international passengers, so everybody tested negative on that flight. When that flight landed in Israel, 10% of everybody on the plane was positive now with a rapid test. So that meant that all those people went from having so little virus that the test couldn't even pick it up. Maybe they truly weren't contagious at the start of the flight. By the end of the flight, they were contagious. Those weren't people who got infected on the plane. That's too fast. You can't catch, it wasn't like everybody was really negative or one person had it and everybody got it and would have already tested positive. The test wouldn't turn positive that quickly. These were people that were in that rapid period of acceleration where the amount of virus that they had in their nose and therefore their contagiousness was actively increasing. That is the challenge, and this is why I have cautioned people about gathering indoors, even with people who are vaccinated and boosted right now, because we know that if you happen to be in that window of time and you are contagious, everybody else in that room, if you stay together unmasked, is likely to get infected too. If they're all vaccinated and boosted, maybe nobody gets sick and maybe you decide that's worth it to you. However, they're likely to all get infected. I think one thing that we have not really accounted for is long COVID. So everybody's really focused on hospitalization and death, and we're focused on economic disruption and societal disruption like schools. We're not talking about long COVID, which refers to this constellation of symptoms that people can get after having a COVID infection. So there was just a meta-analysis that was done in tens of thousands of patients that showed that 80% of people had symptoms that persisted for several weeks once they recovered, and half of people still have a symptom, at least one, persistent from their COVID infection 6 months after they got sick. So the challenge is, if you have everybody, literally, or almost everybody in the world getting this all at once, that is potentially the largest mass disabling event of our lifetime. Some of those people are just going to have persistent shortness of breath, and that's going to be annoying for them, but they're going to be able to do all their regular functioning. But some people are going to have cognitive dysfunction. They're going to have what people are calling brain fog that prevents them from being able to do their job. These are people who are not going to be able to go back to work in their normal position anymore. You may have athletes who have persistent heart dysfunction or lung dysfunction, and those things would be important for anyone. But for somebody who's an athlete who makes a living with physical activity, this is permanently disabling, and so forth. So I think that we can't focus only on hospitalization and death. We have to think societally, and we have to think for our kids about long-term outcomes. We don't have any proof at this point that there will be, a long-term, very severe, totally unforeseen event related to this virus. Like, not something that emerges in the first 6 months, but shows up 6 months later when it seemed like everything was fine. I want to be very clear so people don't say they're being alarmist, they're being, reactionary. We have no proof that if you're totally fine 6 months after your COVID infection, that something's going to suddenly happen to you. However, I think that as an oncologist, I have to caution you that we have viruses, not just one, but lots, that years after you get infected with them cause serious health consequences. Hepatitis B and C cause liver cancer. HPV causes cervical cancer, throat cancer, penile cancer, anal cancer. There are multiple viruses, HHV8, EBV, that cause lymphoma. So this isn't like a theoretical one-off thing. Even viruses that don't cause something that is, potentially life-threatening like that. The chickenpox virus, part of why we all get vaccinated against chickenpox, is that can get reactivated as shingles when you're an adult. So we have no evidence whatsoever that this virus will do that. However, viruses do this, and we have to be mindful when we just say kind of let it rip, Omicron seems milder, let's just let everyone get infected. There's a lot we don't know because this virus didn't exist to our knowledge 2 years ago. So I just say that to say we have to think about long COVID as a potentially disabling event, and we have to think about late health effects of this virus that we couldn't know yet.
I think to stamp on that too, like we've seen folks not be able to continue their work, not do their jobs because of the disabling effects of long COVID, and not just fatigue or so forth, but word finding issues, cognitive issues.
Todd takes care of these patients, to be clear.
And so it's really eye-popping to see how it can affect folks who were previously very well. Marathon runners. I mean,
share de-identified just kind of
Sure.
anecdotes. I think it's helpful for people to hear.
Yeah, I think in our military population, right, we've got really fit people. We have really fit people, and we have triathletes, marathon runners, and so forth. And we've had people get COVID and have a mild course, but then develop long COVID for now a year after, and not be able to continue military service. And so it's so disabling that they're not really able to, walk 200, 300 yards without feeling short of breath or fatigued. And so I think that we're in the nascency of understanding long COVID. There are trials starting just now looking at, I think you guys have all heard fluvoxamine and maraviroc and these other drugs, but we don't have a good way to treat long COVID. So it's just something that we just have to, I think, bear witness to and talk about, because it's not just, staying out of the hospital. It's a disabling infection. So a lot of things, David Osceola has put us on the spot with, but before that, I'm going to defer a little bit. Yes. So if you're looking at KN95, remember N95 is certified by the U.S., KN95 by China, and there are other ones, right? So Brazil, Germany, they all have their own agencies, and so they'll have different sort of labels. And KF94, South Korea. But what I like is that our CDC, if you look at CDC and type in KN95 CDC, it'll take you to their website where NIOSH they've actually tested these, right? And they have a list of all the ones that they've tested that actually meet quality standards of the U.S. So I would buy those, just cross-reference if you're buying them on Amazon, and you will see, you can't avoid it, that 60% of them were identified as counterfeit.
Yeah.
And so they'll have lots of pictures of different products and say, this is the labeling that you can see in counterfeit products, and so just be careful when you buy. So we talked about long COVID, how scary it is, and but I think the thing in the room is like, all right, we're facing a decision, right, about going back to school. We've talked about what can we do, how can we upgrade our masks, what can we do about lunch, and some of the parents, I think, including us, still think about, is it even safe to go back? Like, what is our duty, right, to health and education? And it's really complicated. So right now, like we're feeling N95 masks, and our kids going back. But
let me tell you concretely.
Yeah.
So I have 2 children who are fully vaccinated and boosted, and I have 1 child who's fully vaccinated and who's not yet eligible to be boosted, but based on the news reports we're hearing, should be eligible next week. So for my kids who are vaccinated and boosted, if I knew that they could eat lunch outdoors, and I am confident in my particular kids that they will actually wear the good mask because they know that their mother has spies everywhere, and if they're without the good mask, they're actually like smiling at me in the background. They know that if their mother hears that they're not wearing the good mask, that there will be repercussions. So me, knowing my kids, knowing that if I send them to school in a good mask that I've assured fits them well, that I'm confident they'll wear, and that they can have lunch outside, and they're vaccinated and they're boosted, and in my case, my kids got boosted at the start of break, so they're 2 weeks past. I feel okay actually sending my kids to school with all of that circumstance, knowing that I think that their odds of getting seriously ill from COVID having been boosted are lower. They're going to have a good mask on that reduces their risk of getting infected a lot, at least during the school day when they can be masked. And in the part that they have to be masked, they could be outdoors. I feel pretty good about that. Does it mean that they won't get infected? No, it's possible that they will, but I think that the odds are far better. In the case of my child who's not yet boosted, my very strong preference would be to wait until booster shots are available, because I think, why would I risk having an infection with all of these issues? At a minimum, then you're talking about a kid being out of school, without educational supports as it currently stands. They're being out of school predictably when they could get boosted and then go and have good odds of being in a good mask and being able to attend for the whole rest of the year. And we've avoided COVID in our kids this far, so maybe they never get this virus at all. Why would I give that up when I expect that this kid can be boosted in the immediate future? So, again, this is a decision that I think every household has to make individually, because it's not just about as simple as like, have they been boosted? Will they wear the mask? Although that is a part of it. It's also, what is the likelihood that your school is going to support having kids be outdoors for lunch and be able to pull that off? What is the likelihood that your kid's actually going to go outdoors? Isn't going to decide they're just going to stay in the cafeteria? And importantly, what is the context of your particular kid? So if your kid has a health issue, some of my children do have conditions that make them higher risk. That's in my brain as I'm doing this calculus as a parent. But it's not just their risk, it's the risk of who they're going home to, right? It's the risk of who else are they exposing in society. So if you have, I'll just give you like a blank example here, a made up example here that's very simple. If you have 2 parents are fully vaccinated and boosted, and they're working from home and they're being very careful about their contacts, and they don't have particular high risk issues, and the kid is fully vaccinated and boosted, and they're going to wear their mask at school properly, and their school's going to let them go outside for lunch, I think that you can safely do that. If that kid comes home, they're less likely to get infected. If they get infected, they're less likely to get severely ill. If they do get infected and come home and expose their parents, probably something catastrophic is not going to happen from that. I think if you take a total extreme other end, where you have a kid who's not fully vaccinated and boosted, who probably can't be relied upon to wear the good mask, whose school isn't going to let them eat outdoors, or they're going to choose to stay inside anyway, who's going to go home to a parent who's a healthcare worker, where an exposure means they're removed from the workforce, where another parent has had an organ transplant, or maybe a grandparent lives with them, or maybe there's a baby in the house who's not eligible to get vaccinated yet. when that kid gets infected and brings that home, the repercussions of that are super different than the repercussions of the first scenario, right? So I think that that's a decision that really has to be made based on the specific considerations of your kid and your family. And it's not just the COVID health part of it either. It's also the learning aspect of it. It's also the mental health aspect of it, because all of us had kids home for a long time. Our kids were home from March 2020 until the start of this school year. We didn't send them back for the 2 days a week in April because they were on the cusp of being able to get vaccinated, and we wanted to wait, sort of just like now with our youngest child. We know the mental health impacts of having kids home all the time, not seeing their friends in the normal way. Like, that has an impact in every single child, to differing degrees, every child. So we are absolutely sensitive to that. I think that, the challenge that we have is, once again, I don't think we're choosing between the two things that we think we're choosing between. I think we think we're choosing between either we close for a little bit or, delay reopening for a little bit, virtual for a little bit, to sort of shore everything up and make this as successful as it can be, recognizing it's an awful situation that we can't make perfect, or we just go. The problem is, it's not going to be like that. We're not going to just go. School will get closed. Whether or not that building is still there and the lights are on and the principal's showing up, school will not be open in the way that you mean when we say school's open, meaning there's enough teachers to actually teach the students, that there are bus drivers to get the students there, that there's someone healthy to still serve them lunch, that there's anyone else sitting in the classroom with them. They will not manage to be open for the month of January, period. It's just not going to happen. And I hate to be so, dogmatic about this. We're trying to think very carefully about the whole range of different types of families and different types of students and different challenges schools face. And we're very, we are not on the Board of Education. We do not represent them. We do not represent Howard County Public Schools or the governor or anyone else. But we're trying very hard to think, like, what would we do if we were all these different people? What would we do if we were all these different types of families? I think the fact is, just like the people that were scheduled to go on those 7,000 flights on Christmas weekend, that got canceled. I think the fact we have to face is this just is not going to work as we currently stand, with a minimum of our school boosted, period, with no plan for lunch, with a guarantee that we do not have even a majority of our students with a high quality mask in their hand, and that very few of them have been told why it's important to wear it. Very few of our teachers have been told why it's important to wear it. I don't know if any of the teachers have had an in-service on how N95s are different than a surgical mask and how you can protect yourself, and can you fold the surgical mask the way that I showed you from the CDC video and put a cloth mask over it. I'm not sure that anyone's ever been taught that. And the reality is, these are schools. This is what school is for. School is for teaching stuff. So at this moment, it might be that what we have to teach is different stuff than what we normally teach. I think we might be teaching about airborne viruses, and we might be teaching about exponential growth, and we might be teaching about what we know from the history of medicine and science about the long-term impacts of viruses, and we're teaching about the healthcare system and what is necessary to keep it functional. We might be teaching different stuff. That's the facts. And we might be teaching that with actions and not with words right now. I think if we just choose to go back, we give our students the message that just because we failed to plan well for this situation in some respects, we never sorted out lunch well enough to have been almost 2 years in a pandemic of an airborne virus. Period. We did not. This is a failure. I think if we just go back, we show them we failed and it's on you guys. We failed and this is your problem. And that's the wrong message. I think we should be teaching a message of accountability, which is we failed to address the fact that this is an airborne virus. We got lucky with previous variants that were less contagious, that were less likely to escape the protection of a prior COVID infection or to escape the protection of a vaccine. We got lucky. Unfortunately, Omicron is here to teach us a lesson, and I'm afraid that if we just go on Monday with no change to the plan from what we did before break, Omicron's going to make us repeat the whole grade. I'm just being clear. I don't mean that like a whole school year is going to have to happen. I'm saying Omicron is going to teach us a big lesson about failure.
in this Romans is you're exactly right. It's students and teachers in the classroom who are not wearing masks correctly with no consequences. I think we've seen a lot of non-enforcement of wearing masks, and some of that has been
Right.
sort of the leaders who need to lead right now, for sure.
Yeah. We've had teachers, and I'm not naming any names, but we have had teachers who have said, I know that you guys are all tired of masks. I'm tired of them too. You don't have to wear a mask in my class as long as you don't tell. We've had substitute teachers say that to classes my own kids were in. We've had teachers say, I know the mask can get uncomfortable. If you need to take a break, you can take your mask off for a while. We've had teachers say, if you want to have a snack in here, I'm not going to tell anybody. Just pull your masks up and down. And these aren't small children that I'm talking about. That's a different issue in kindergarten or something where these kids are used to having a snack. This is different. I'm talking about middle school and high schoolers who can go 3 hours without eating, I'm positive. Short of people who have medical reasons that they have to have food, in which case they probably need to be going to visit the nurse. There's not a need to be snacking in classrooms. So there are ways to do this, but I think that again, I say this with deep respect to the board. I say this with deep respect to Dr. Martirano, to all of our principals, to all of our teachers, and to our governor, because I think all of you guys have done a phenomenal job in this pandemic. I think that we have failed to plan for the fact that this was always an airborne virus, and now we have a highly contagious immune escaping version of it, and we never sorted out lunch. We never ensured that everybody had a quality mask in their hand. We just didn't do this. We did not message about boosters or even vaccines. We get the notifications, same as all of you guys, every day, right? 13 people tested positive in our high school today. You'll get contacted by a contact tracer. You don't have to do anything. Just keep doing what you're doing. Every one of those messages was a missed opportunity to say, if you aren't vaccinated, go. Because these cases are showing us that there's spread in our schools, and you can protect yourself. If you're not boosted, go. You'll have protection in 7 days, and you'll have a ton of protection in 14 days. Go right now. It's clear the cases are going up every day. Every single one of those emails we got that did not say that was a missed opportunity to convey something vital for function of society and for in-person learning. Every one of those messages was a failure. So we have to fix that. We have to. Vaccines aren't controversial. They have been made controversial, and they cannot be. We already require a ton of vaccines to attend Howard High School, to attend every HCPSS school, to play a sport, to go to camp. We have required vaccines forever. This is not new. This is not controversial at all. It just is not. So we have to get away from the idea that this is controversial. So the other thing that I will say, because as a physician I would be remiss if I didn't say it, is that we have to consider a vaccine mandate in our schools for children who are eligible to be vaccinated, because the alternative is this. Will there be some parents who are upset about it? Absolutely. Will there be some parents who are furious about it? Absolutely. Respectfully, there are a lot of parents who are already upset and furious about things, period. And failing to get our kids vaccinated and boosted is going to impair learning for everyone. We don't let students come in and scream at the top of their lungs in their classroom. We don't let students come in and bring a weapon to the classroom. We don't let students come in and do things that interrupt the educational experience for the whole good of the school. We have to forget about the idea that this is a political thing. We got to give that up. Because if we want our children to go to school, this is it. They got to get vaccinated and they got to get boosted. We've given almost 9 billion doses of vaccine worldwide. We have half of the world now fully vaccinated. 50% of the world is fully vaccinated. These aren't experimental. They're not new. The side effect profile is well understood. Serious side effects are extraordinarily rare, and even more rare in children. So the idea that we're not going to mandate this vaccine the same way we mandate so many other vaccines to attend school is frankly crazy. The fact that it hasn't already been decided is crazy, but we have got to do this.
And schools that have done it are successful. And so there are folks who have taken their kids out of public school to go to private schools where vaccine mandates are required, and they are successful along with routine screening as well. So one question that's come up is this is this recorded?
Yes, so this is being recorded. You will be able to watch it after the fact. We're going to do our best to put together a frequently asked questions about this for people that weren't able to see this at all, or may not use social media, or even may not have internet access. Again, this is not an official HCPSS sanctioned event. This is something that we organized with our own high school PTSA. So whether or not the county wants to send that out, I don't know, but we will be sure to post that, the FAQs in a public place. We're getting a lot of questions related to immunocompromising cancer and so forth, which I guess makes sense because that's obviously the area of concern, and I am an oncologist. I will say a few things. One is that for anybody who missed this, we covered this a little bit in the earlier part where we know that for some people who are immunosuppressed or immunocompromised, the vaccines work less well. And if you are immunosuppressed or immunocompromised, you are eligible to get an additional shot beyond the booster shot. It needs to be 28 days from your last shot. And if you go on to the Maryland Vaccines website or anywhere, you can usually put an additional shot in immunocompromised, and you will see that there. So you can get an additional shot. Even with that, though, some people still don't form a good immune response. There is a product that has been authorized by FDA within the last couple of weeks called Evusheld, EVUSHELD, which is an injectable monoclonal antibody. It's a shot that you get. It can be repeated every 6 months, and it provides protection against COVID. It is not a replacement for the vaccine. You should still get vaccinated, but as an added thing that you can do. It's only for people who are immunocompromised. It is currently authorized, but in very short supply. If you go and ask your doctor for this tomorrow, if my patients ask me for this, which literally happened this morning, we don't have it yet. Maryland doesn't have it yet. We will have it. It's just starting to be made, shipped, and so forth. So if you are somebody who's immunocompromised, or immunosuppressed, or you know someone who is, that is something that you should have on your radar screen that's very beneficial, that can dramatically decrease your risk of becoming severely ill with COVID.
And the other thing too, with timing of boosters, people have asked this, you don't have to wait the 90 days that some people have thrown out there. So if you're 6 months after that second dose of Pfizer or Moderna, or 2 months after J&J, you're eligible to get that booster. You don't have to wait, even if you had COVID. What we say is that if you're test positive, no symptoms, just wait your isolation period, and once you're done, then you can go get your shot.
Yeah.
Or if you're symptomatic and you're test positive, right, just wait till your symptoms are better and you've met that isolation time to come out of isolation, and you can go get your shot right away. The only thing that we talk about with the 90-day period is that if you happen to receive a monoclonal antibody, then you want to wait 90 days after that, or convalescent plasma, which hasn't been used for a while now. But that's sort of the one nuance there.
Yeah, with the antibodies, I think a lot of people have seen in the news, like the antibodies are great and then the antibodies don't work. So what happened was monoclonal antibodies, which are just sort of like making the component of your immune system that we think is responsible for a lot of the benefit of a vaccine, the antibody that will attach to the virus and keep this from infecting you or keep you from getting sick from the virus. There are ways to manufacture that artificially and give that to people who have or haven't been vaccinated in the past. So those are called monoclonal antibodies. They're antibodies that we manufacture in a lab as opposed to making in your own body. There were several of those that were created, that were authorized. With the Omicron variant, unfortunately, almost all of those no longer work. There's one that still works. It is a newer one of those, and at the moment, the supply of that is so limited that even for immunocompromised, very high-risk people, there's not a sufficient amount. So what I will tell you is that we are in this kind of window period where that product is also being scaled up in terms of amount that exists and amount that's been distributed to the states. It will increase, but at the moment, it is extraordinarily limited. And incidentally, this is another point I should make as we're thinking about, you know, the question that gets asked a lot, which is like, if this is so contagious and you're saying even vaccinated people are going to get it and everyone's going to get it, why don't we just get it? Part of why is that I've just told you about something that we can give people who are immunocompromised, who might not respond as well to the vaccines, to keep them safe. And it exists, and it's really effective, and it's been shown in clinical trials it's really effective and it's safe, but we just don't have much of it yet. I've told you that we have a monoclonal antibody that works really well, but it's only one brand left, that still works against Omicron, and there's not that much of it, and we just need to make more of it. And the thing I didn't tell you yet was that last week, 2 different pills were authorized by FDA to treat outpatients who have a 5-day course of pills to treat outpatients with COVID-19 that reduce the risk of being hospitalized substantially. One of them reduces the risk of being hospitalized by more than 3/4. Those also are now authorized, but in extremely short supply. All of these things are being made. All of these things are dramatically being increased, but at this moment when we're about to have a huge surge of Omicron in January, the supplies of every one of these things is so limited that I think the odds of any individual on this entire thing listening getting any one of those is almost zero. Nationally, people will get them, but the odds that, I don't know how many people are watching this, but the odds that anybody who's watching this would get any of those products right now if they wanted to is zero. So that will change too. And so again, we're reopening at this moment when we're in a surge of cases, when we're having millions per day, and that's doubling every day and a half, when we have drugs and other products that we know are good to prevent this and to treat this and to keep people from being hospitalized, but we just don't have enough of them yet. So this is like the perfect storm of things being hard in January, that if we chose to delay reopening, to shift our school year slightly, to go virtual for a few weeks, we could offset a lot.
Some other questions have been like, how long do you have to wait between other vaccines and getting your booster, like Gardasil or Shingrix vaccine, and now we can give them at the same time. So we don't wait. We used to wait 2 weeks between vaccines to just see, are you going to have side effects from this one or not, and to kind of know that. But now I'll see Travel Clinic and I'll give 4 or 5 vaccines, including the COVID booster, at the same time without any problem. The question about, well, like, what if I was exposed to COVID? CDC has some good recommendations on, you know, what should you do? And it's based on if you're vaccinated, and that really means getting that booster as well to be truly fully vaccinated. But for most people, you can still get the booster shot, right? So as long as you're wearing a mask and monitoring for symptoms, you can get the booster shot. CDC doesn't have a specific wait this long after your quarantine period is over. What else?
Yeah, I think
I guess I kind of wanted to crowdsource this a little bit. Someone had mentioned, I think, Phelps Luck Elementary School. They do outdoor lunch very successfully with parents, monitoring. And someone asked, like, for Howard, when we asked when the principal reached out, I think, and asked for volunteers, what was the response? I'm not privy to that.
So I don't know I'm not sure if we've asked for volunteers. If Principal Novak, unfortunately we don't have a way to like him to speak or something, but if he's on here, he can certainly answer in the chat. I don't know if he specifically looked for volunteers for outdoors. If so, I totally apologize that I missed that email. We get lots of emails these days, as you can imagine. But we would happily volunteer to do that because we really do think that this is important. Somebody's asking a question that I believe is about whether or not it's possible to get vaccines at school. I'm not sure if that was the thing. So one of the things that we had talked about is if we decided to have a delayed return to school or a period of virtual school in January, it's certainly in the first half of the month to let people get boosted and figure out lunch and so forth. Could we actually use that time to prepare in an additional way as a school? And one obvious way would be, could we even have booster clinics that were physically located on the school property, like in the parking lot or something, to be a central place that's already close to where folks are and get them vaccinated. I don't know if Howard County Health Department has mobile units to be able to do that. I certainly know that there are lots of healthcare workers, amongst the Howard County Public School System parents, who I'm sure would be willing to come and give shots. We know how to give shots, so we could certainly do that.
Thank you, Mr. Novak.
I see a message. I don't know if I think Mr. Novak is on, I don't know if that's Facebook or Instagram. I can't keep track. He's on Instagram, but he said volunteer sign up for outdoor supervision is coming. So that's great.
And there's a lot of parent interest, like just seeing here to kind of bring it. And we get it that winter weather is upon us, and this is going to be hard for sure. And teachers are saying that we're losing admin support.
somebody put a question or a comment about complications of the vaccine. So let us just address that actually, because I do think that some people have been nervous about getting the vaccine because they worry that like their kid will be the one. We're parents, like we worry like that too, right? So I mean, I can give you a specific example. One of my children has a severe peanut allergy and has had anaphylaxis multiple times. The Howard County Emergency Department knows us, despite our best efforts. So so we were nervous because we knew that we had heard these reports that the mRNA vaccines, Pfizer, which was, the one authorized for that age group, but Moderna has had it as well, have a risk of anaphylaxis. And so we were anxious about that. And we carefully considered, where are we going to do, are we sure we want to do this? Where do we want to do this? In that case, because we thought he's likely to be higher risk than the average person, we know people who've had severe allergic reactions. I'm not talking about like hay fever or like, you're allergic to your cat. I'm talking about like you have an EpiPen or you should have an EpiPen. Please get an EpiPen if you ever had anaphylaxis. Those kind of people, those people we know are higher risk to be the ones to develop anaphylaxis, but even still, these are extraordinarily rare events, like a few in a million people, and they actually become less likely to happen with time. So like if you didn't get that in your first shot, you're super, super unlikely to get it in your second shot, and even less likely to get it with your booster. So what we know is that these are really like a few in a million people who are getting that, even that first dose of booster. Even for the people who have a history of anaphylaxis, their risk of having anaphylaxis is well under 1% with the first shot and falls to 0 by the time that you get to the booster shot. So in our case, we chose to give the first 2 doses to our son in a healthcare setting. And then the third shot, we felt sufficiently comfortable that we did it in a tent outdoors in Baltimore, in a mass vaccine site, just like everybody else. Like every person who has anaphylaxis, you should carry your EpiPen everywhere. We carry that EpiPen everywhere, and we brought the EpiPen with us that day. They do have people on staff at every single vaccine site trained to recognize anaphylaxis, have EpiPens on site, and administer them. So even if this is like a freak thing that happens to you or your kid for the first time, every place that gives vaccines is ready for that. But you should know that the odds of that are like winning the lottery odds. Like that's probably not going to happen. I think the other thing that's been a concern is myocarditis, so heart inflammation. And I think that the message, the concern about this has been that although this is an exceptionally rare event with these vaccines, that it has been most common in teenage boys. Doesn't seem to be really an issue in the adolescents, in the younger kids, possibly because the dose is lower. So the dose for 12 to 15-year-olds is low. The dose for 5 to 12-year-olds is lower. The dose when we eventually get it for younger children will be even lower still. And it may be just that lowering the dose was enough to take care of that issue. So this hasn't really been an issue for the 5 to 12-year-old kids. But for the older teenage children, teenage boys seem to be the highest risk group to get this, although it was still exceptionally rare. The thing to know about that is no one has died from myocarditis from the vaccine. The hospitalizations that have happened, when they have happened at all, have been very brief. And the majority of people who have even gotten myocarditis, already an extremely rare event, in most cases, those people have recovered at home within 1 to 2 days and been fully asymptomatic with absolutely nothing other than like rest or Reston, Tylenol or something like that. This has not been. I don't want to say something like that is not serious. I don't want to tell you any medical condition is not serious. However, these cases have been things that have been self-limited. People have recovered from them, and they've been really, really rare. The other thing to say, though, that's more important is that the risk of myocarditis from the virus itself is actually several-fold higher than the risk from the vaccine, even for that age group. So if you're really scared that your kid's going to be the one to get myocarditis, get them vaccinated, because they will get this variant, guaranteed. If they're in the schools, or if they're unmasked with anybody, they will get this variant, and their odds of getting myocarditis from the virus itself is far more than from the vaccine. So do we have other questions? I feel like lots of streams of things have been coming in. We're trying to look at like Instagram Live, Facebook Live. People are emailing stuff. My daughter's like handing me pieces of paper from something.
Oh, Laura asked, with this current variant Omicron, and people have said Omicron and Omicron, we all accept both. Is that okay to say?
I think if there's anybody who actually speaks Greek, we apologize that we're butchering this.
Yeah. But Fauci says Omicron, but you'll hear Omicron. Regardless, how long is it going to be here? So the question has been like, is it going to be here just kind of briefly and run through and cause a bunch of infections, or is it going to stay? And Laura, thanks for the question. We don't know how long it's going to be here. Someone also asked, is this the beginning of the end? There have been some great papers on that, great op-eds on that, and we would love for that to be the case. And it might be, when you look back at the Spanish flu of like 1918, like this is kind of the evolution of this respiratory virus, was that it became more transmissible but caused less severe disease, and that was a change that happened. And then we saw it kind of turn into something that was more in the background, respiratory viruses of the population. So that's we hope that that's what we're witnessing. We're obviously in unprecedented times, right?
I think the other point, though, is that the implications of getting infected aren't going to be the same in April as they are now,
Right.
or as they were a year ago. A year ago, we had no therapeutics, right? We didn't have monoclonal antibodies. There were no pills. At the moment, we've got them in the sense that the clinical trials have been done. We know that they work. They've been authorized by the FDA. They exist. They just have to be manufactured. We just have to scale them up so that they physically are, like, these are pills that you can now go to the drugstore and get, or these are products that, in the case of a monoclonal antibody, you can now, go and receive this infusion or receive this injection. We just have to scale these things up. But once these things are plentifully available, I don't want to say it won't matter if you get COVID, but it won't matter as much, right? Because the pills are expected to be effective against not only all the variants that have existed thus far, but all of the ones that we're likely to see in the future. They just work in a slightly different way than the vaccines to protect you from getting severely ill. So again, I don't want anybody to go get a virus for no reason. However, I do think that when we have these pills readily available, which isn't that far in the future, they already exist, they've already been authorized, the implications of getting infected aren't going to be the same. The implications of getting infected are going to be, you got to go to your pediatrician's office and then you got to drive to the pharmacy and pick up your pills. It's not going to be like it is right now. The problem with right now is we don't have these products yet widely available to be able to give people. And the other problem with right now is if everybody needed them at once, even if you just needed to go to the doctor, even if the pills existed at this moment, if suddenly 300 million people in our population all just needed an appointment, we're doing our best here, but there aren't that many of us. There aren't that many doctors even to be able to see everybody and give them a prescription, right? So this is the other reason we just have to spread things out. Like, we just have to get a few months from now. January is going to be horrible. I think January is going to be the hardest month that many people alive have ever lived. I'm just being honest with you. I think there's going to be so much disruption in so many things, from school to services that you rely upon. We've seen pharmacies already having to close because they can't staff themselves. We've seen grocery stores already be unstocked entire aisles because the truck didn't arrive because the drivers were sick, or there was no one who wasn't sick to stock. We've already seen this kind of stuff. As I said, we saw 7,000 flights canceled on Christmas weekend. And I can assure you the airlines didn't want to cancel those if they had a choice. So we're going to see a lot of disruption. January is going to be awful. February is going to be it's going to seem much better compared to January, but we're going to still have a tail end of a lot of people in the hospital. And then I think things are going to get a lot better for all those reasons,
Corey Pollitt, thanks for your question of risk of Omicron with autoimmune disease. I'll be honest, I haven't refreshed on that. Have you read anything?
It's too new for us to say, and I'll tell you why I say that. When people get infected, it's not like they get infected and then immediately the terrible thing happens. If something terrible is going to happen, what happens is you get exposed, and then an average of 3 days later you get infected, and then several days after that you get sicker, and then you get admitted to the hospital, and then you get worse in the hospital, and then you die, if you're going to die. We just lost.
Our phone just died.
Speaking of things that died, we just lost one of our feeds. I don't know if that was at Instagram. Or actually, here, plug it into this one. See if we can reconnect. Sorry, hang on. We're trying to reconnect the other phone. Okay. So I apologize for the people that missed that part. But the bottom line part of this, though, is that Gosh, now I lost what am I talking about? No, I forgot. What was the question? All right, hang on. I forgot the question I was even answering. Oh, yes, autoimmune. So the bottom line is the course of illness is not immediate, and this virus is just too new. So to answer the question of the person who said, what about people who are immunocompromised, which I think was somebody on the phone, on the platform that we're still on the phone, so hopefully you're hearing your answer that you needed. We don't know yet. The virus has not even been in the U.S. Confirmed for it's been just 1 month. I think once we get a better handle on enough patients getting infected, we'll see, are the people with autoimmune disease getting less sick with Omicron. I can tell you that I have had some patients and friends anecdotally that have cancer or that have other immunocompromising diseases who've had what is probably Omicron, because we know that at the time they were infected, it was at least half and maybe 3/4 of the variant in our area. And all of them were vaccinated and previously infected or vaccinated and boosted. None of them were sick enough to need to be hospitalized. Some of them were sick enough to need to be in the emergency room. So I do think that they still get sicker than people who don't have that added risk factor, but my impression is they get less sick than people with the previous variants and the exact same health history and vaccination status. So I think that we are
At 3 o'clock.
we're at 3 o'clock. We went 30 minutes past what we were planning to do. So if anybody's still here, you're amazing. I'm sorry that our device died, that we were on the other platform, but I think we're going to close here. We will look through all the questions. We're going to try to save all of this, and we'll put out a frequently asked question. If we didn't get to yours, we will answer it. And we will post that somewhere, if nowhere else, I think hopefully on the Howard High School PTSA website. And we'll see if the county is interested in distributing this to other schools or if other PTSAs are interested in sharing this. So thanks to all of you for your questions. I apologize for the technical issues. Like I said, we had never done Facebook Live or Instagram Live till 2 hours ago, ever. It's our first time. So, however, what I can do competently, in addition to hopefully be a doctor, what I can do competently, however, is tweet. So if you go to Twitter, I tweet as TM Prowell, M for Michelle, TM, and then my whole last name. And I try to post everything there, and I will do my best to cross-post things to Facebook. I'm not sure I got the spirit for Instagram, but I'll do my best to cross-post things to Facebook as well. So thanks to all for your attention. Bye-bye.
Thanks, guys.